Come to the second discussion on upper GI bleeding. And in the last one, we discussed that upper GI bleeding can present as hematemesis or melena. It may be a combination of hematemesis and melena, that's the other way. Or it may be, if it's a mild bleed, it could be occult blood loss, a person coming with anemia. Or if the upper GI bleeding is very severe, torrential bleeding, the blood may passage through the gut very fast and they can even present as an acute severe bleeding PR. And the first discussion we concentrated on a person who presents with a hematemesis, and then it was a quick assessment, resuscitation, then with the history and examination trying to find a cause, but ultimate diagnosis is by endoscopy. And then if it is a varices, we learned what are the methods to treat a esophageal varices. And of course there I tried to demonstrate the video of banding, but unfortunately it didn't play, so I'll start showing that, and I have explained the steps there.
Blend of the endoscope with the ligating unit attached is
So you can
pressed
see,
against the
you can
varix.
just listen to this.
Once complete contact is made around the varix, the suction of the endoscope is activated, drawing the varix into the housing. When a varix is suctioned completely into the housing, a readout may be observed. The handle unit is then rotated clockwise 180 degrees until an audible click is heard.
So it described it very well, and after keeping the scope, the varix is sucked into, and of course the endoscopic view you saw, you see the varix is coming into the endoscope. It should completely fill your field. Before that you should not let the band off, because what will happen if you let it before the entire thing gets sucked in, the band will not catch the varix, it will just, the band will get wasted. So you have to apply suction, let this get fully pulled in, then how can identify that you will not see any mucosa, you just see the varix filling, and you should not let go the suction, or keep on pressing the suction until then. And then you saw the circular thing which the control with rotation, it is actually fixed at the where your hand controls are there of the endoscope, and when you rotate until you hear a click, you proceed, and then the band will be released and it will catch at the neck of the varix. So it's a very elegant technique. So that's the video of your how varicose banding is done. And now we'll take the next commonest cause for upper GI, the hematemesis, is the peptic ulcer bleeding. And of course again as earlier, of course you go through resuscitation, a quick history examination, and endoscope will of course make the final diagnosis that it is an ulcer. So if it's a bleeding peptic ulcer, just pause the video, use your background knowledge of your medicine, your pharmacology, and just write down the steps that you will do in a bleeding peptic ulcer for definitive management. The resuscitation, of course, is there. What are the steps? So pause and write, and it's better to check your knowledge on this, and to compare and see. So I'm sure you have written that you have to start on a IV proton pump inhibitor, and then of course some the minor bleeds may just settle, but if it's a significant bleed, you can do some intervention with the endoscope. Actually you can see, I mean, just some little bit of a minor gastritis or some few erosions, no active bleeding, of course that would be fine. But if you see some bleeding, you can actually get some control with the endoscope. So there are endoscopic methods. Earlier what were actually mostly available was the injection of a dilute adrenaline, but now of course there's glue and various energy sources, and now recently the clips are also available. Now if the worst, one of the worst bleeds you can get in a bleeding peptic ulcer is when the duodenal ulcer erodes into the gastroduodenal artery. It can cause a severe bleed, and this type of severe bleed in the past, of course, necessitated surgery. Had to open the duodenum and apply two sutures on either side of the bleeding vessel. But uh, thanks to the technology, now clips are available. So if you see a spurting artery, you can actually clip on either side. It's of course needs some experience to do this, but of course it's available. So even a arterial spurter you can control with clips. And there's also another point. Now with the endoscope, what are the one thing is, if you see arterial spurter, there's no doubt it's a severe bleed. Or even if you see a large adherent clot, I don't think it's a good sign. It's a bad sign, because this clot is just temporarily pressing, because there's you can't get a complete tamponade. It's a hollow viscous, and at any stage this clot will break and start bleeding. So these two criteria actually labeled as endoscopic criteria of a severe bleed: visible spurt, arterial spurter, or a adherent clot. In those, the intervention should be very active, because otherwise they can go into another catastrophic bleed again. And of course, if your endoscopic methods are not successful, this happens especially in these severe forms of bleed. Of course, sometimes you may be compelled to do some surgery, like you do a partial gastrectomy. So if you see a malignant as a severely bleeding, maybe you can resect that. Or a gastroduodenal artery, you can do a duodenectomy and suture. So these are surgical techniques. Of course, you do this if endoscopic methods are, are failing. And as I said, the endoscopic criteria of severe bleeds are the arterial spurter, or you see adherent clot. Now pause the video for a while and write down clinically how can you predict, even if you before you doing endoscopy, clinically how can you predict a severe bleeding, where you have to be very alert. Actually, they have to be very closely monitored. So just pause and write. Of course, they are very obvious. One thing is, of course, so you can now start when you are finished, you can restart the video and listen. If in spite of very active resuscitation, if you can't keep the patient, you can't get the patient well resuscitated in spite of active resuscitation, that means there's a severe bleeding going on. Or if you're just managed to get the blood pressure to a certain level, but you have having a massive transfusion requirements, it is also not good. You're just keeping losing blood, but you're keeping the blood pressure because simply because you are replacing, it is also not good. And or other thing is, if you get a rebleed, that is if a person gets a hematemesis, settles for a while, and gets another severe bout of hematemesis, that means inside thing is not settling. So these are clinical criteria of severe bleeding, and what I mentioned were endoscopic criteria of severe bleeding. And also you have to consider treating H. pylori. This is not it's not urgent, but once your bleeding has settled, you have to check for H. pylori and you have to treat. And also, so these are the things that we discuss, the criteria which will predict a severe form of bleed. So that's how you manage a bleeding peptic ulcer. The other things, of course, the other causes are straightforward. They're goal directed. Like if you have a aortic enteric fistula, the prognosis is of course very poor, but still the only way to salvage is that you do a emergency surgery and then do a aortic aneurysm repair, so that the bleeding will get stopped. And I'm sure in future the endotherapy with the covered stents may come into place. Maybe there are centers doing, but in our country, of course, it's still what is available for acute aortic fistula. It would be surgery, but of course, carries a very high mortality risk also. If it's a malarious, manage conservatively. If there's any reason why the patient is having the vomiting with a lot of retching, you may have to address that. PPI IV is indicated, but it will settle down. And like if it's a malignant tumor bleeding, initially you try to get some control, and of course you have to treat the malignancy appropriately. So this is the management of a hematemesis, and hematemesis is due to upper GI bleed and the causes and management. Supposing your patient presents with melena. So a male, 50 years, he complains of melena. So again, we have to discuss the management. So what I propose is again, pause the video, take about 15-20 minutes, write down your management, and then listen to the discussion. That is the best way that you can uh, upgrade your knowledge, and also it will help you to remember. If you have practiced that, compare and then redo it. That is the best way rather than just listening. So again, if the melena is very severe, and also we have to remember that of course some cases the person may even come collapse. So the first thing would be to assess your vitals and do the resuscitation necessary, and then of course you take a quick history. Now in a melena, what is the difference? That it could be upper GI bleed, any bleed up to the ligament of Treads, or it could be anything beyond the ligament of Treads, the small intestine, and also the right side colon. So when it is a melena, your differential diagnosis is broader than a person coming with hematemesis. But if it is a hematemesis plus melena, then it is likely to be a upper GI, because the melena is just the later show of your the upper GI bleed. But if it's a melena only, you have to consider the upper GI, the causes that we discussed earlier. And also, of course, I have not listed here uh, the others, mine cause like vascular malformations, and also malarivice, the bleed later may have a minor degree of melena, but these are the major causes if there is melena. And then the small intestine pathologies, it could be a tumor in the small intestine, and one of the commonest cause for a small intestine bleed is of course a Meckel's diverticulum. And as you know, in a Meckel's, a peptic ulcer can form and it can bleed very severely. Crohn's doesn't bleed to a great extent, but of course it can be considered as a cause. And then of course, right colonic malignancies, like the cecum or the ascending colon. So now your history for the upper GI causes we have discussed. So revisit your previous one and think what is a quick history you're going to take. And with these all these things, uh, especially the tumors and Crohn's, you may have a history of like suggestive of some form of subacute obstruction when they have central abdominal colic pain, some distension, feeling nauseated, and also definitely they will be losing weight with tumors and Crohn's, because with Crohn's you have a significant number will have malabsorptions. So those features will be there. In Meckel's also you may get this bit of dyspeptic history. Then right colonic carcinoma, and before the melena, they may be losing blood for some time, and so they may have a history of pre-existing before your melena start, a history of iron deficiency anemia. So cardiorespiratory inquiry, they will have shortness of breath, shortness of breath on exertion. And also right colonic carcinoma cecum, it may start infiltrating in the ileocecal valvular region and causing into a or gradually developing obstruction. So right colonic carcinoma also may have, just like a small intestine tumor or Crohn's, features of a subacute obstruction in the past. And like any malignancy, they may have other features of malignancy like loss of appetite, weight, and if it's spread to the liver already, some right hypochondrial pain, or again if it's infiltrated the right ureter, it may have cause a right hydronephrosis and a dull loin pain. An examination, upper GI causes we have discussed. So in these, you may feel masses due to tumor or Crohn's also can cause mass, especially in the right iliacosa. Right colonic cancer, they will be pale, and of course, in some cases there may be a right iliacosa mass, and of course, if there are secondaries, there may be a hepatomegaly. So it depends. Of course, sometimes you may not find any positive physical sign if they are early diseases. So, but anyway, so now how am I going to confirm? Because definitely you will have need endoscopy. So you have upper GI causes, small intestine, and the right colon. So the best way to investigate is exclude the upper GI causes by doing an upper GI endoscopy, because it's the easiest to perform out of the endoscopy is to reach. But of course, if you feel a definite right eye like for some mass, then it may be not that necessary, but still for completion you may do, because you are bleeding maybe from upper GI cause. It's always better to exclude upper GI cause. And if it's negative, then for the right colon you do a colonoscopy. And you can visualize what the problem is. Now if that is also negative, if this is also negative, and when you do the colonoscopy, if you see melena coming, the melena colored fluid coming from the ileocecal valve, then of course you have to think of a small intestinal cause. So what are the methods to look at the small intestine? Again, pause the video and just write down what are the methods available to visualize the small intestine. Okay, so you, and once you write, open the video again and then check. So the investigations available to look at the small intestine is, one is of course contrast enhanced CT, computed tomography, that you will be able to see small bowel tumors, evidence of Crohn's, and Meckel's diverticulum. So it's a good investigation. In the past, before contrast CT was available, people used to do what is called, of course, you can do a barium meal and follow through, but of course, the follow through, your barium in the stomach gets released in pulses, so it won't give a very good picture of the small intestine. But there's another technique called the small bowel enema, where you pass a NG tube with the guidance of a endoscope. You place the NG tube into the duodenum, and then you instill barium directly through the tube into the small intestine, which is called a small bowel enema, and it is much better than doing a barium meal follow through. But the CT would be definitely better than a small bowel enema. Then, if in centers where there are facilities, of course, enteroscopy is there. So with enteroscope, you can have a direct look at the small intestine. And other one we know, in the centers with facilities, they have what is called a capsule endoscopy, which will you will enable actually to see the entire intestine. So anyway, so your first approach is to do upper GI endoscopy. If negative, do a colonoscopy. If not, you have to look at the small intestine. Now these are endoscopies methods to look at the intestine. And in case of a bleeder, what are the other techniques available, especially where you can't access the access is not easy, like the small intestine, or supposing even in the right colon, if the bleeding is severe, sometimes doing the colonoscopy is difficult, because the blood will come and keep on touching your lens, and it's difficult to perform. So in case of severe bleeding in the colon, and also definitely in the small intestine, to identify a bleeder, what are the other things, other investigations, even upper GI bleed, you can see from that. But generally upper GI endoscopy is not that difficult. You can just suck things and get control and be easily visualize. But in these situations of difficulty, in case of bleeder, what are the two tests available? Pause the video, write the two answers, see whether you get 100% or 50%, or very unlikely you get 0. But the test in case of bleeding, one thing is of course angiography. Uh, Only thing is, for angiography to be sensitive, the bleeding has to be active. The bleeding rate has to be to a certain significant level. Otherwise, your angiography will not demonstrate the bleeding. So you can actually localize in what part of the bowel the bleeding is happening, because it is important, because in case that you have to embark on surgery for a GI bleeding, you should know from where it is bleeding, because when you open some, if you are lucky, you may see a mass lesion like a colonic cancer. But in other cases, it's like minor vascular malformations, you can't, they are not macroscopic, and the entire intestine is filled with blood. You just don't know from where it is bleeding. So in those cases, of course, you will have to uh, do you have to localize. So therefore, this it's important. One important way of localizing is angiography, and there should be some degree of bleeding for that. If the bleeding is minimal, then the other test that can be used is uh, a isotope scan, red cell tag scan, and in that you may see the site of bleeding. So these are the methods to visualize where it is bleeding. And the management of upper GI bleeds we have discussed. And then these again, if you find the cause, some will need surgery. Most of these will need surgery. But for like a vascular malformation, you have also, you can resect the segment after localizing, or of course angiographic embolization is also possible.